morning. Seems like every time I come, there's new technology up here. This is really cool. Yeah, I may have to give a talk. This morning, I'm especially happy to introduce Dr. Rob Spencer. Dr. Spencer has been at our hospital since 1996. He now directs the pain management program. He's one of the innovators and creative thinkers on staff. He's a great resource for our patients, my own patients. His background is in anesthesia and pain management. He told me that in college he took a year off. Was it a year off? Yeah. Took a year off in college and worked as a nurse's aide at the Connecticut Hospice. He took a year off from Yale, where he was training. And then years later, from his pain management fellowship in Vermont, he spent time going back as a teacher in the same Connecticut Hospice. And that sort of closed the circle for him. I've been privileged to have Dr. Spencer contribute to the hospice program since he's been here, and I'm grateful for that. Today he's going to talk about managing pain 100% of the time at the end of life. Dr. Spencer, thanks.
Can you hear me okay? Okay. Some of the technology is new to me. I'm not quite sure why we have a... when it says okay, you just click okay, right? Before I get started with the talk, I want to make a pitch for Concord Hospital's Pain Rounds. This started in the summer, and it's been fairly well attended. About 25 to 50 people come. It's every Friday, it's the third Friday of every month from 12 to 1, and it's at the VNA boardroom at the Yapel building. And it's a chance for people to hear a brief presentation on some pain-related topic, and then to present cases that are difficult pain management cases that they want some input from myself and other folks from various disciplines that attend. It's also a chance where, in addition to networking with other providers, we as a group try to look at systems issues. How can we manage pain better as a community, not just for one individual, but for various people? So I just thought I'd make a pitch. There's also free lunch provided. So why am I here? Why am I giving this talk? I was approached by a colleague of ours several months ago who had a friend who was an influential politician in the state who shared an experience of two friends, or I think one was a friend, one was a family member, who had recently died. And in one case, the pain was very well managed at the end, and in the other case, it was not. And he understandably felt that 50% success rate was not appropriate, and was considering proposing legislation to try to improve pain management. And my response was that I didn't think we needed more legislation. I think what we needed was more education. And I think it's not just an issue of education about the tools, but that's part of it. I think it's also looking at the process, how we manage pain at the end of life, and where does it break down. So I agreed to try to develop a talk that would look at that, and that's what this is coming out of. Now, why isn't pain managed well at the end of life? There was, how many people know about the AHCPR guidelines for managing cancer pain? There's a cancer pain management and a acute pain management one. These were put out by the Public Health Service, the U.S. Health and Human Services Public Health Service Agency for Healthcare Policy and Research. And I strongly encourage you to get a copy of these. There's a copy of version for clinicians. There's one for patients as a handout. It really covers a lot of material very well. There's a shorter, easier to read 50-page booklet that is very helpful. These were put out in 1994. This has been put out frequently by the American Pain Society. The most recent edition, I think, just last year, the 4th edition. If you read this booklet, and if you need help finding one, I'll let my office know and we'll put you in touch with where you can get one. You'll know more than 90% of practicing clinicians in America. And if you put it to practice, you'll really be going 99, if not 100% of the way towards getting all of the pain managed at the end of life. The AHCPR report brought out different issues that were barriers to management of cancer pain in particular at the end of life, and they divided it up into issues that were related to the healthcare system, issues that were related to the patients themselves, and issues that were related to healthcare providers. Issues about the healthcare system involved, in essence, a low priority given to pain management. I think this is actually improving in the years since 1994. Recently, the accrediting bodies for hospitals, nursing homes, even for HMOs have included pain management as part of the accreditation process. So I think the priority towards pain management has improved. Hey, Ray, is this set to go automatically? Because it's going forward without me pushing the button. You still there? Oh. Inadequate reimbursement, I don't think really has been addressed. I think it's ironic to share with you that I trained as an anesthesiologist. I'm a board certified anesthesiologist, and then I went to get extra training to do pain management, and I actually get paid less doing pain management than I would if I were doing anesthesia. And the part of my practice that involves helping patients at the end of life is probably at the lower end of the reimbursement scale compared to other things I do. The reimbursement does not emphasize pain management in life as a priority, unfortunately, but I think that the trend may be changing as the priorities change. The restrictive regulation of controlled substances, there are some regulations that are problematic, but I don't think that they need to be barriers. In New Hampshire, the only restriction regarding opiates is that you can write a prescription, a single prescription for only 100 units and for only a month's supply. That can be a pain, so to speak, to deal with, but it's not as restrictive as some other places where they require triplicate prescriptions for opiates. The way to get around the 100-unit supply is simply, if it requires more than 100 units for an interval between the time that you're seeing the patient, there is no rule against writing multiple prescriptions on the same date. You need to date the prescription on the same day that you write it, but you can write on the prescription, please do not fill until some future date, so that you can write enough prescriptions for a given patient until your next visit with them. As far as availability of treatment or access to treatment, I think that, yeah, sure. No, whenever you write a prescription, the date on the prescription needs to be the date that you sign it. You cannot date a prescription for a week away and then sign it. But if you date it today, you can write on it, please do not fill until any time in the future. But the prescription has to, the date of the prescription, you can't show up, if your patient showed up at a pharmacy with a prescription with your name on it and a date down the road, that may be a problem. As far as availability of the treatment, I think that's improving. I think in Concord, we really have made great strides. There are places in the state and other places in the country where that's still a major issue, getting access to particularly some of the more advanced techniques. Problems related to patients' reluctance. This is an issue that I think is a matter of educating our patients, that when we manage their pain, we're not also ignoring the workup and treatment of their illness. I think that's a fear that patients have that was identified as a barrier. Patients sometimes are afraid to complain about their pain because they feel that that will mean that they're not a good patient. And this also is our responsibility to educate them that pain management is an expectation that they should have. Fear of addiction and unmanageable side effects and tolerance to medications, we'll talk about some of those issues. I think that's also a matter of education and really shouldn't be a barrier to management of pain at the end of life. Pain is always, some people ask me, is this patient having pain that's psychogenic or emotional, or is this physical pain? And my answer is, it's always both. Sometimes it's more one and less another, sometimes it's less one, more the other, but the International Association for Study of Pain defines pain as a sensory and emotional experience, and it actually defines it as either involving tissue damage or described in terms of tissue damage. For example, the person that says they have a broken heart, according to this definition, has pain. So don't think of suffering and pain as completely distinguishable. They go hand in hand. What I'd like to look at now and focus on for a period of time is what I'm calling the pain management cycle. This is a process that we go through when treating or diagnosing or managing any problem in medicine. But sometimes, particularly in pain management and particularly at the end of life, instead of thinking of it as a cycle, we get into a linear mode of thought and we jump from somebody has pain, well, let's give them the morphine or let's do this. And we don't go through the process of assessing the pain, diagnosing it, treating it, and palliating it. So I think the breakdown in the system happens along this cycle, and I'd like to spend a little bit of time talking about each component of the cycle. Clearly, you have to start with pain assessment, and assessment is a process of first being told that there is pain, but then trying to determine as much as you can about the pain. The term assessment, very interestingly, has its origin in the word to sit, and particularly to sit at the side by a judge. And I thought that's really neat, because how many times do we get a chance to sit at the bedside and really try to gather all the evidence and judge what's going on with a patient in pain? These days, it's not too common, but that's the origin of the term. The other problem that we have quite frequently is that when we assess a problem in pain management these days, we're often not right with the patient. We're at a distance, perhaps not as far as Jim Lowell was when he talked to Houston, but we often have to rely on information that's given to us from family members, from hospice nurses that are visiting the home, and there's always this problem with verbal communication and breakdown. You know, the telephone game where somebody says one thing and it gets passed along. The information changes, and that's a limitation in the system that we can talk about as well. What's the range of information that we're looking for? Clearly, we're trying to identify the description of the pain, the location, the quality, the onset, all of the things that are listed. But if possible, we try to find out as much as we can about the context in which the pain is occurring. These are patient-specific contexts, but it is also a matter of learning about where the patient is in their culture, where the patient is in their religious or spiritual beliefs, what past medical problems or treatments may be affecting the issue. This is the full range of things. Now, obviously, every time you have a problem with a patient, you're not going to sit down and try to get all of this information, but it's important to get at least the basics before you go further in the process. And the very basic part is intensity. I think if you don't ask something about intensity, then you won't have a baseline with which to judge the effectiveness of any intervention that you choose to make. There are a variety of pain scales out there. The 0 to 10 pain scale, where 0 is no pain at all, 10 is the worst pain imaginable, is one scale that we've tried to make in use in Concord Hospital and the surrounding communities as consistent as possible. If one place uses one scale of 0 to 5 or 1 to 5 and another place uses 0 to 10, then patients get confused and the numbers don't necessarily mean as much when you compare from one setting to another. The other thing is it's important, I think, how you anchor the scale. If you say 0 is at one end, that implies that you may not have pain. I think that's better than putting a 1, which has at least some value to it. At the other end, it's important too. What you say a 10 is may change what kinds of answers you get. If you say 10 is the worst pain you've experienced, then if you ask somebody to rate the range of their pain, the high and the low, everybody will say it's their high is a 10 because that's the way you've defined it. If you define it as worst pain imaginable, it gives a broader spectrum, and somebody may have not experienced the worst pain they can imagine, and if they experience a new pain, it may be worse than the most recent pain that they've had that's been the worst. This scale is very helpful. On the other hand, it has its limitation. It's a unidimensional scale, and as we talked about before, pain by definition has an emotional component and a sensory component. I don't know how many of you have experienced, but I often will have patients, when I ask them what their pain is on a 0 to 10 scale, tell me that it's a 12 or a 20. And what does that mean? I don't think it means that they're being flip. I think it means that they believe we're asking them to rate their sensory pain on the 0 to 10 scale, and they want to tell us about their emotional pain. And the only way they have to do that is to say, it's off the scale. And what that means is I'm suffering. Not only am I having sensory pain that's very high, but there's an emotional quality, there's a suffering component that's extreme, and I want to tell you about that. It may be helpful, not necessarily with patients, but in your mind to think of a two-dimensional scale, to think about pain that may be up as high as a 10 on the sensory experience. Let's see if I can, yeah, as high as a 10 on the sensory experience, but very low on the emotional suffering scale. And an example of this I would give would be my wife, Louise, when she was in labor with our first daughter, Anna, told me that this was the worst pain she had ever experienced. And the nurses at University of Vermont were amazed that there was an anesthesia resident's wife who did not have an epidural. But even though she was describing this as the worst pain in her life, she was happy. She really loved the fact that she was giving birth. This was not an emotional suffering experience, even though it was an intense, painful experience. And we had a very good birth experience despite intense sensory pain. The other example is somebody who may have a very low sensory pain, but a very high emotional suffering. Now, Anna's 2 years old. Now, when she was 2 years old and she fell and scraped her knee, the knee may have felt fine, but she was upset and suffering. And anybody that has kids knows that there can be a lot of emotional component with relatively minor sensory. Now, anybody that's seen patients knows that can happen too in your office. You have patients where there may be some identifiable source of pain, but the intensity with most people would be relatively low on a sensory component level. But for whatever reason, given their background, given their experience, given their psychiatric illness, if that's an issue, there's a lot of suffering, there's a lot of emotional components. So that would be somebody that's up in the 10 range on the emotional level, but maybe somewhere in the lower range in the sensory experience level. When you get to end of life, it's not uncommon to have high sensory experiences of pain. There are reasons for advancing illness or treatment that may cause nerve problems or true high levels of sensory pain. At the same time, at the end of life, because of spiritual issues, emotional issues, there's a lot of emotional component of their pain. So they may be up in this far upper right-hand corner, and unless you both address the sensory issue and bring that level down, and the emotional issue and bring that level down, you're going to miss the boat. There are a lot of pain scales out there. These are pain scales that are common use, but there are others that are helpful for pediatric patients or patients that can't use numbers. This clearly, as you can tell from the faces, elicits information not only of a sensory nature, but of an emotional nature. So it gives you both at the same time. So that's the assessment part. And why do we assess? It's to determine how quickly we need to cycle around the process, but it's also to try to determine, if possible, what the source of the pain is, what the diagnosis might be. The word diagnosis just simply means to know and distinguish, and it's really at the heart and soul of medicine. It's what we do all the time. There's nothing special about pain management compared to diagnosing other problems, and in fact, one study showed that 80% of things that people come to primary care doctors for in their office involve some pain. So the concept of diagnosis should not be left out of pain management. It's a key element and very important to do. Diagnosis is based on history and physical examination, on objective tests. I'm going ahead without me here. It'll make the talk go very quickly. The historical findings, we had looked at some of the issues around the pain history, and it's very clear once you think about it that as soon as you start hearing somebody describe their pain, you're starting the process of diagnosing. If I said I was a 65-year-old man and I was having pain that was located in my chest, and the quality of it was that it was squeezing, it felt like an elephant sitting on my chest, it was a pressure. Its onset was when I was playing tennis, and it got progressively worse, and then I rested and it came down and its intensity was high, and it got its associated symptoms were sweating and I was short of breath. All of you are thinking that I have cardiac problems, okay? We're already starting the process of diagnosing it. Similarly, if I said I was a 50-year-old woman and I'd had a mastectomy and my chest pain was in the breast that was absent, you'd be thinking phantom breast pain, which occurs just like any phantom limb pain. We're already starting the process of diagnosing. Don't forget to do that. I think that's one of the biggest places where the system breaks down is we hear that somebody's hurting, we hear that it's a 8 out of 10, and we jump to conclusions without really assessing and diagnosing. Treating the pain. If we've been successful at diagnosing the source, there are often very specific treatments available. And that's why we do it. If we had no difference in treatment based on the diagnosis, if every pain was treated with one medicine, then we wouldn't bother. Treatment, the term actually was interesting as well. It means to drag about or handle or pull. And I was thinking about the term treatment for different kinds of pains, different kinds of processes at the end of life. I think a lot of patients that undergo treatment for cancer might feel pulled or dragged about or treated in that way. Treatment options, including chemotherapy, radiation, surgery, it's clearly beyond the scope of the talk and my expertise to talk about these, but I did want to mention that each of them has potential for causing pain. Chemotherapy and radiation therapy can cause neuropathies, and they can be persistent or can be transient. Surgery always causes some acute pain that needs to be addressed, so don't forget that in addition to treating the problem that you've diagnosed, you need to be assessing and treating the pain syndromes that can come out of those problems. If there's been no effective treatment available for that particular diagnosis, or a diagnosis is never really determined, even though you've tried to go through the cycle, the next step is to palliate or control the pain. And the term palliate means to cloak or conceal or cover. And that's interesting to me because people often don't make the distinction between treating pain and palliating pain. And if you think about it, there is a distinction. As you go around the cycle, it's important to realize that you don't stop when you get to palliate. You go on to reassessment. And that's a big area where things break down. Often people will assess pain and over the phone or in some context through this telephone channel, an intervention will be made. But unless there's a process of assessing the response to the intervention, you get lost sometimes. So it's a matter of going through the process, then reassessing, and if the intervention didn't work, you still go through the same process. And it's a matter of then deciding, well, is the diagnosis that we're thinking is the source of pain correct, or is it wrong? Did we miss something somewhere? If you still think it's correct, then you go through and you increase the treatment or change to a different type of treatment or add palliative measures at the same time. But you still have to go through that process in an ongoing way, not in a, once you've done it, it's a line and you're done, okay? There are many palliative care modalities, and I think that it's important to realize that just like particular treatments were based on the specific diagnosis, different palliative care modalities also are appropriate for different kinds of pain. There are many medications. I think people often forget the physical therapies, the simple ones like ice or heat, the advanced ones like TENS or even acupuncture. And I think acupuncture, within the next several years, there's been enough scientific evidence to prove its efficacy for pain management that it really will become a part of conventional medical practice and not considered an alternative therapy. The psychological and spiritual approaches need to be used particularly for those patients whose pain has the psychological and spiritual components. And almost everybody at the end of life at least has some degree of that going on. There are a variety of techniques that involve ablation of specific nerves. This is where I tend to get involved. That is helpful for fairly localized pain. If we have time at the end, we can talk about that, but I don't want to focus a lot of energy on that. There are a lot of medicines, and I'm going to focus now on, there's several classes of medicines that we use to palliate pain. There's the opiates, and we'll talk more about that. There are the non-steroidal anti-inflammatories. Antidepressants and anticonvulsants are very helpful, and a variety of other miscellaneous ones. Within each class, there's a whole bunch of individual agents, and there is no way to expect any one person to master them all. I think it's important to pick a few agents within each class and get comfortable using them. It's kind of like when I first learned how to cross-country ski, I had waxing skis that you had to put clister on and stuff, and there was a whole range of waxes from the hardest to the softest, and there were like 10 of them. And not only that, but there were different companies, and each of them had 10 of them, and I didn't know what to use. And somebody said, well, just pick a hard one, pick a medium one, pick a soft one, and the clister, use it, and get out there and ski, and then as you learn more about the quality of the snow, how cold it is, how wet it is, you'll get better at picking the waxes. The same thing applies. Pick a few that you feel comfortable with, and then expand your repertoire as time goes by. That's what medicine's all about. That's why it's called practicing medicine. The various sources of pain, whether it's coming from nerve or bone or viscera, suggest probable types of agents that may be helpful. This is not a hard and fast rule. This is a where do I start? Any of the agents may help with any kind of pain, but in general, nerve pain tends to respond better to the antidepressants and the anti-seizure medicines, and tend to be less responsive to the opiates and the anti-inflammatories. But that used to be dogma, that you don't use the opiates or you don't use anti-inflammatories. But in fact, people are recognizing that it can be helpful to use the opiates and anti-inflammatories for nerve pain. It's just less likely to be as helpful as some of the neuropathic adjuvants like the antidepressants and anticonvulsants. Conversely, bone pain responds really well to anti-inflammatories, to non-steroidals or to steroids. It responds fairly well to opiates, but it tends not to respond as well to the neuropathic adjuvants like anticonvulsants. Visceral pain generally responds well to opiates, and certain kinds of pain respond really well to anti-inflammatories, colicky type pains. Just like there are different, the reason for establishing which is the source of the pain may help you to determine what agent to use. There are common descriptors that patients use. They describe burning, shooting, electrical tingling, lancinating, those kinds of descriptors for pain that tend to be nerve origin. They describe an aching, localized pain for bony pain, and a crampy, diffuse within a given region pain for visceral pain. So those descriptors can at least get you started even when you first assess the pain to determine at least what tissues may be involved so that you can pick appropriate palliative agents. There's many, many non-steroidal anti-inflammatories. It's important to recognize, though, that they fit into different classes. They're different categories of the anti-inflammatories. And the reason that it's important to recognize that is that there's a lot of individual variability from one person to the next on what anti-inflammatory medication they may respond to. So one person may respond really well to ibuprofen, but not very well to Indocin. And vice versa for another person. There's no way to predict, except based on past experience in that individual, which anti-inflammatory is going to be most helpful. So the trick is, learn a few of them so that you're comfortable, but if one doesn't work, do try another one, but not another one in the same class. Pick another one in a different class that may be more helpful for that individual. The newer COX-2, the cyclooxygenase inhibitors that are specific for the type 2 receptor, are new, are kind of the hot thing these days. They have fewer side effects. They're better tolerated, but there isn't any evidence that suggests that they're better in terms of managing the pain. It's just that they're better tolerated. Tricyclic antidepressants, more than the serotonin-specific reuptake inhibitors, have been shown to be very effective for pain, and for nerve pain in particular, but for other pains as well. If you are using a tricyclic and then start a serotonin-specific reuptake inhibitor for depression, if you're using a tricyclic for pain and then choose to use a serotonin-specific reuptake inhibitor for depression, recognize that you may need to lower the dose of the tricyclic at the same time, because the tricyclics do act at the serotonin system even though they act at the norepinephrine system as well. The fact that they act at both systems is probably why they're more effective for pain management. Again, there are a variety of them. Pick a few. Amitriptyline and nortriptyline are probably the most used. Nortriptyline has a shorter half-life simply because amitriptyline is converted to nortriptyline in the body. So if somebody is having grogginess in the morning and you want to use a shorter acting agent but they've had good effect with amitriptyline, just switch them to the same dose of nortriptyline. Desipramine and imipramine are less sedating, and in fact, desipramine may be activating for some people. So if for your patient they find that it's activating, it's best to use it in the morning rather than at bedtime. If somebody is on a monoamine oxidase inhibitor for their depression, be careful not to use meperidine, Demerol. That's a known interaction that may be lethal. There are a variety of anticonvulsants available, but really gabapentin has become the favorite. It's very well tolerated with reasonably few side effects. You don't need to check blood levels. And so it's been probably superseding all of the others. I generally, for pain that's really out of control, will start with about 300 milligrams a day, and then 300, then 600, then 900, and go up by 300 milligram increments. For pain that's been around for a period of time, and particularly somebody who's on lots of medications, I'll start with 100 milligram tablets and go up by 100 milligrams every day to a maximum of 2,400 milligrams, which is what the seizure upper limit is in the PDR, but in pain management, people are going up as high as 3,600 a day for controlling pain, and it's working at some of the higher doses, even though it's not working at the moderate range doses. It's a divided TID to QID dosing, but it's a very good drug, and I think in some pain management circles, it actually has become a first line before the tricyclics, simply because more people tolerate it. There's some other membrane stabilizing agents that act like the anticonvulsants for nerve pain. Lidocaine can be given intravenously, and mixilotine is an antiarrhythmic that's an oral analog of lidocaine. There's some other miscellaneous adjuvant medications, corticosteroids, psychostimulants, antiemetics. Clonidine is very helpful and actually is the one drug other than morphine that's FDA approved so that companies can market it for epidural use, particularly for cancer pain. It's been shown to reduce the opiate requirement as well as probably reduce the development of tolerance. Sorry about this. It really is making me talk faster. There's some specific adjuvants for bone pain. Strontium-89 and the bisphosphates are helpful, particularly for bony invasion of tumors. But the opiates are clearly going to be the mainstay for a lot of patients' pain at the end of life. And I think it is very important that you gain familiarity and comfort with a few of them. Now, this list seems like a long one, but we can exclude some of the medications based on the problems that may occur. For example, propoxyphene, Darvon, Darvocet, and meperidine, Demerol are ones that you probably should avoid using. There's really no advantage to these medications, and they have active metabolites. Meperidine is metabolized into normeperidine, which can be neuroactivating and can cause toxicity with chronic use. People start to twitch, people start to hallucinate, and if it's neuropathic pain, it can actually make their pain worse. The neuroactivity of the normeperidine can make the neuropathic pain worse. The only indication in my mind for Demerol on the formulary is for shivering in the PACU or for Rigers. Small doses of Demerol seem to be better than any other opiate for treating that problem acutely. For chronic use, there's really no role for Demerol or meperidine, and Darvocet potentially as well has these problems with chronic use. So that crosses those two off the list, makes it a little bit easier. And remember, by the way, I'm going to bring it out again because this has caused deaths. If you have somebody that you're going to give Demerol to for whatever reason, and they're on an monoamine oxidase inhibitor antidepressant, you're courting disaster. Several of them are probably inappropriate to use at the end of life for the reason that they're agonist-antagonist drugs. Those have ceiling effects. Most opiates do not. You go up as high as you need to go. When you're an anesthesia resident and the attending asks you, what's the proper dose of any opiate, the answer is enough. And you give enough until either the pain is controlled or you have dose-limiting side effects that are unmanageable, and then you determine that the pain's not opiate responsive. But the agonist-antagonists do have a ceiling effect with regard to their efficacy. If you give more and more, after a period of time, they stop doing more and more. So that's one reason not to use them at the end of life, where the expectation is that you may need more and more. The other reason is, if you get into the circumstances where you're mixing an agonist-antagonist drug with a pure agonist drug, you're going to run into problems. If somebody's on a long-acting pure agonist like a fentanyl patch or something else, and you give them for breakthrough pain Talwin, your antagonist effect is going to predominate because the opiate receptors are already occupied by a pure agonist. You displace some of them with an agonist-antagonist, and you actually have less effect, and so more pain when you give this breakthrough drug. It's a good reason to avoid them altogether as we're talking about which opiates to use at the end of life. So it boils down to really only a few, so it's not like the shelf of waxes becomes a small selection, so it's a little bit easier. And the advantage of fentanyl, hydromorphone, oxycodone, and morphine is that they all have, in addition to being not having truly very active metabolites, although there's some issue with morphine, they all have long-acting preparations either available or soon to be available. Hydromorphone is apparently, there's going to be a long-acting preparation coming out soon. That's a 24-hour release hydromorphone. Fentanyl has the fentanyl patch. Oxycodone has OxyContin. Morphine has the MS-Contin and the generics, as well as a once-a-day Cadian preparation. So that's another advantage to these medications. I put methadone down in blue because it is a pure agonist. It does not have active metabolites. It's very, very helpful for pain at the end of life. There's some data to show that it may be more effective than any of the other opiates for nerve pain, because in addition to acting at the mu receptor for its opiate effect, it acts at the N-methyl-D-aspartate, the NMDA receptor in the spinal cord, which is helpful for neuropathic pain. So there's some reason, if you think that somebody has nerve pain and you're going to be on an opiate, to choosing methadone. The caution is that because of its very long half-life, the duration of action changes over time. As you first start it, it works for about 4 to 6 hours. As you use it over a period of a few days to a week, it can last up to 8, 12, and over a period of time, some people even get 24 hours of relief out of methadone. So that's why I included in the category of ones that you should think about using, but just be aware of that. The other issues with methadone are that, this kind of gets back to the prescribing regulation stuff. If you're prescribing methadone for addiction, you need to have a federal license as an addiction program. If you're prescribing it for pain, you don't. What I suggest to people that they do is, if you're using methadone for this purpose, just simply write on the prescription for pain, and it will avoid a call potentially. I've never heard of anybody being called, but in theory, it might make somebody wonder what's going on, why is somebody prescribing methadone. As more and more people use it, I think pharmacists and regulators probably won't even think about making these calls. But anyway, if you write for pain on it, I can't imagine that there'll be any trouble at all. Yeah. Sure. It's cheap. That was the next thing I was going to say. Absolutely, and that I really was going to say that, but I'm glad you emphasized it. So, the reason for using long-acting medications are clear. We're all familiar with the therapeutic window, and that's this comfort zone where the vertical axis here is blood level of an opiate. The horizontal axis is time. If you have a blood level where the pain is controlled and you're in that comfort region, but you're not so high that you're getting side effects, that's the therapeutic window. If you use a short-acting agent on a frequent basis, you have relatively high peaks and relatively low troughs, and are more likely to get out of the therapeutic window into the side effect range at the peaks, into the pain effects at the troughs. The answer for this is simply to use a longer-acting agent so that you spend as much time as possible in the therapeutic window and avoid the need for patients to take repeated dosing. There is no law that says, though, that a patient's pain has to be constant. It's quite common, in fact, for patients to have some degree of background pain that's at one level, and then to have these blips, like shown here, where the pain goes much higher. How do you deal with that? You simply use a long-acting opiate to cover the continuous component of the pain, and you add a short-acting agent to cover for the breakthrough pain. Now, if it, as in this example, the breakthrough pain is so intense that the amount of opiate that you need brings you up into the side effect area, then you simply need to treat the side effects, or try to pick something like an adjuvant in addition or instead of the opiate for breakthrough pain that doesn't cause side effects, or use the non-pharmacologic approaches as well. If you don't forget that, I think you'll be probably going a long way towards helping with these breakthrough pain problems that are really intense. One of the common ones that people have, not so much at home, but sometimes, but also in the hospital, is dressing changes. And if there's a very predictable, very regular, intense intense burst, you can anticipate that by giving medications before. Same with before baths. There are some very short-acting options. For example, if somebody's in the hospital and you're doing a dressing change, IV fentanyl would be shorter acting than morphine, and if it's a very short problem, there's now also available an oralet of the fentanyl lollipop, which people can use for breakthrough pain. So there's a lot of options, there are a lot of tools, but don't forget the non-pharmacologic approaches to try to deal with some of the breakthrough pain as well. The side effects of opiates, sedation can be managed often with caffeine or with psychostimulants. Constipation needs to be managed. It happens all the time. There are virtually no patients who will not get constipated on high enough doses of opiates. And I've been in a pain program where the motto was, the hand that writes the opiate prescription also writes the prescription for the laxative or the agent to increase motility or stool softeners. The issue of nausea and vomiting really is variable. Some patients have that as a major problem, some don't. The anticholinergics, the phenothiazines may be helpful. Itching happens particularly with agents that release histamine. Morphine is one of the worst offenders. Fentanyl is actually one of the best. It does not release histamine, so there's much less itching with that. Respiratory depression really only happens of significance in terms of frequency with opiate-naive patients. It's very rare with patients that have been on opiates for a period of time. And stimulation, or if you really need to use antagonists to reverse respiratory depression, be very careful because you'll precipitate a painful crisis. So it's best to try to stimulate them and use titration rather than a large dose initially when somebody's opiate naive. There's some other strategies in addition to the use of medications to treat the opiate effects. If you switch, just like different people have different responses to various classes of nonsteroidals, different people have different side effect profiles for different opiates. And it's a matter of sometimes just switching to a different opiate where for that individual person there may be less nausea than a different one. So switching has that benefit. Switching also has the benefit of incomplete cross tolerance. If somebody's been on one opiate for a period of time, their body may have gotten used to that opiate to an extent that it's not as effective as it was initially, or you've gone up on the dose. The molecules are slightly different, so when you go to a different opiate, there is some tolerance to that opiate, but not as much. So if you use the equianalgesic dosing table and calculate an equivalent, you may find that you can get away with using less of that for the same effect in terms of their pain. And the fact that you're having a dose-sparing effect because of the incomplete cross-tolerance may mean that you then have fewer side effects. So there's a couple reasons for just trying to switch to a different opiate as an alternative strategy. Just like we showed before, using a longer-acting agent rather than repeated doses of short-acting agents avoids the peaks and can reduce side effects. Using non-opiate adjuvants and non-pharmacologic techniques reduces the opiate doses. If somebody's side effect that's limiting their dose is something related to the GI tract, nausea, vomiting, paralytic ileus, it's often helpful to switch to a route of delivery that does not involve enteral administration. So that could be a patch, that could be a subcutaneous infusion, an IV infusion, or it could even be targeted delivery into the spinal, either epidural or intrathecal. Some other problems related to opiates, tolerance, dependence, addiction, and pseudoaddiction. You need to know what these mean so that you can educate your patients so they understand what the issues are. Tolerance is simply a matter of, for many patients, but not all, if you use a medicine over a period of time, the receptors accommodate, you have less effect for a given amount of medication, or you require more medication for the same effect. Either way, there's tolerance developing. It's unclear what the frequency is at the end of life. One of the issues that you need to be aware of is not to attribute tolerance. If somebody needs more pain medicine, it doesn't necessarily mean they're getting tolerant. It may be that their disease is advancing. It may be that there's another new problem that needs to be diagnosed and treated. That's why we have the cycle. So you don't forget to go back and think, is there something to be diagnosed or something to be specifically treated? Dependence happens universally. If somebody's on enough opiates, they will always have a withdrawal syndrome if you abruptly stop the opiates. Is this a problem? No. You simply don't abruptly stop the opiates. If you reduce the dose for whatever reason, do it by no more than 10 to 20% per day to avoid the opiate withdrawal syndrome. It's not a problem as long as you don't abruptly withdraw it. But it universally occurs. Addiction is a compulsive seeking of the drug, not because of its pain-relieving effects, but because of the psychic effect, the high that you get from it. And this is despite physical or social harm. If somebody gets high on it and they're on it for their pain, that's not a problem. That may be a nice thing. It's if somebody is seeking the drug out for other than pain relief and it's causing physical or psychological or social consequences, that actually is very rare in pain management in general and in end of life in particular. So even though that's a fear both on the part of patients and on the part of providers, it really should be a non-issue at the end of life once people are educated that it's rare and that you monitor for it. And in the very, 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 I really, in the end of life, it's not an issue. And if we're talking about chronic pain, we can get into some other discussions about it. But I really counsel you to not let you or your patients consider addiction or fear of addiction to be a barrier to effective treatment. Now, there is this concept of pseudo-addiction, and that is patients will often seek the drug very emphatically and look like they're addicted, when in fact they're not seeking it for the psychic effects. They're seeking it because it helps with their pain, and their pain's not well controlled. So be careful that you're not attributing somebody's behavior of wanting this drug to addiction when it's really that their pain is not being managed and they're not getting enough of the medicine. And how do you know? Well, you give them enough and their pain goes away and the behaviors that seem appropriate go away as well. If it doesn't go away and they're still having pain, then you can use other modalities besides the opiates. These are just the signs and symptoms of abrupt opiate withdrawal. Be aware of this in case somebody is starting to complain of these symptoms. Did they run out of their prescription? Did they stop it for some other reason? Are they on an oral agent and they didn't want to tell you that they're not taking oral agents now, and now is the time to maybe get into a different route of administration? So you need to be aware of these things so that if they start complaining of them, you can ask whether they've stopped their opiates. This is a model guideline for the use of controlled substances that was put out by the Federation of State Medical Boards. New Hampshire is a member board. I don't know for a fact that they've adopted this model guideline, but it clearly states that the board, the Federation of Boards, encourages physicians to view effective pain management as part of their responsibility. It's part of what you should be doing, and that you should not fear disciplinary action by the board based on using controlled substances appropriately in the course of your legitimate medical practice. The times people run into troubles with the boards are when they're prescribing for a friend, for themselves. They're not documenting the patient interactions and not documenting the appropriateness of their assessment and their diagnostic workup. If you are treating a patient and you're doing appropriate medical care and you're documenting it, you really should not fear any problems with the board. If you're not doing it appropriately, then obviously, like any other medical inappropriate behavior, it's a concern. The World Health Organization, I'll just quickly show, has a 3-step ladder that is used more as a teaching tool than anything else. The idea is when you have mild pain, you start with a non-opiate adjuvant like an anti-inflammatory or an adjuvant like the neuropathic pain medications or others, depending on the source of the pain. If the pain is moderate, you go up to the next level where you use a weak opiate like codeine or hydrocodone combined with non-opiate adjuvants. I'm not sure that you need to not use a strong opiate in low dose, and there's no inherent reason, I think, to start with a weak acting agent. The idea, though, this World Health Organization structure is used in other countries where access to opiates is even more restrictive, and it's a concept that you just think of low and work your way up. But I think it is appropriate, particularly with severe pain, to use a strong opiate, but don't forget to also use appropriate adjuvants so that you can reduce the opiate requirement and potentially the opiate side effects and the opiate costs. The World Health Organization 3-step ladder really just talks about medications. I think it's helpful to think of a pyramid of pain management modalities that doesn't just include medication. Think in your mind non-opiate medications and simple non-pharmacologic techniques like heat and ice. For mild pain, for moderate pain, go to the opiate medications. Moderate pain, go to opiate medications, but remember the adjuvants. And at that point, it may be appropriate to go to some of the more advanced non-pharmacologic techniques like a TENS unit, like acupuncture. But for severe pain, in addition to the opiate medications, it may be worth considering some of the advanced medication delivery systems like PCA, some of the non-destructive interventional techniques like nerve blocks that we can get into discussing if you want. And then for severe pain, it's appropriate to consider destructive interventional techniques. One of the most gratifying, for example, would be patients that have pancreatic tumors and have severe abdominal pain. A celiac plexus block with local anesthetic takes away their pain for a period of time, and then the local wears off. That documents that that's a site that we can attribute, that we can intervene. You then do either a chemical or thermal lesion at the celiac plexus, and patients can be pain-free for months before the nerves regenerate, and if their life expectancy is a period of 6 months and their pain relief is gone for that 6 months, then we've really accomplished a lot. As we're trying the different modalities, whether it's different medications or different parts of the pain management pyramid, each time we try something new, it's a matter of thinking the process through. Go around the cycle. Is it not working? Is the diagnosis that we're treating correct? Is there a specific treatment available? And if not, is there a specific palliative measure that's appropriate to the diagnosis? As you're going around this cycle, if you get dizzy, remember, you're not alone. There's, in addition to you and the patient and the patient's family, a team. This is my chance to pitch the hospice team. The attending physician or provider is a part of the team. You have the relationship with the patient. You're the best person to bridge the connection from curative processes to one of comfort measures. You shouldn't be sending the patient to the hospice. You should be participating in the team as well. The hospice nurse is a very key element in terms of communicating the pain assessment, but also have become very expert in treating pain. I encourage you to listen to their suggestions. The spiritual caregivers through hospice programs, the other therapists and counselors, volunteers, pharmacists, either in the hospice program in some places or in the community, can do compounding of different agents if they're not available. Bereavement counselors get very little press, but I think they do a wonderful job of assessing family members' risk for bereavement before death and then working with them afterwards. Home health aides, I can't tell you, when I was working as a nurse's aide at the hospice, I was an inpatient, so it wasn't a home health aide, but I did this kind of work of bed baths and things. You get told a lot of things by somebody when you're giving them a bed bath that may not get communicated to the nurse or to the physician, and I think if you don't use that relationship that the home health aides have to glean information, to try to help, you're not getting the benefit of all of the things that they can do. I didn't mean to skip through social worker quick, it just went fast. Social workers, very important in terms of getting access to community resources. Hospice medical director, I think we're very blessed to have Rick, who's very capable, who's available to be a consultant, who oversees the team. But even the hospice team, when it is going around this cycle, can get dizzy. And remember that there are surgeons, radiology therapists, oncologists, and pain management physicians like myself who are available to the team as consultants. So nobody's alone. This is all a very collaborative process. And I'd like to end just with a quote from Albert Schweitzer: "We all must die, but if I can save someone from days of torture, that is what I feel is my great and ever new privilege. Pain is a more terrible lord of mankind than even death itself." I'd like to stop here, and I realize that we're out of time. If people need to go, that's fine. If people want to stay and either discuss specific cases where they've been stymied or things have not gone the way they would have liked, it may be helpful to think through the process and see if we can learn where it's broken down. I also brought some teaching examples for practicing converting different opiates. If people want to practice using the equinalgesic chart, I'm more than happy to go through those cases with people if you have time. But I'll end the formal lecture here.